Thank you, sir. My respected Professor Mukherjee and Professor Mujumdaran Chair, Professor Amol Banerjee Dean ICP. I am very much privileged to find my teacher, Professor M. K. Rai, Chairman, API West Bengal, and other delegates in the House. Let's move into another horizon. Professor Guho has explained how the challenge is being met when two dangerous diseases are meeting, diabetes and HIV. And it's time to meet another challenge, contraception in a young lady and place of HRT in the background of diabetes. Possibly, the practice of contraception is very much existing since existence of human being. And pregnancy should be very much spaced, planned and well designed. It should never be an accident. And to prevent this accident, all these methods are being practiced over the time. We know in case of lactational amenorrhea, this is prolactin, which is suppressing growth hormone releasing hormone, which is suppressing LH, and finally the lady is running with anovulation. We know in case of barrier method, we are having both male and female condoms, but to note, they should not be used simultaneously. It should be used separately, otherwise they may adhere and they may be displaced. Regarding diaphragm, I want to mention that diaphragm has to be kept for at least 6 hours after the event, but it should not be prolonged. It should not be kept there for around 24 hours. That can lead to toxic shock syndrome in case of diabetes. We are very much afraid of using IUD in the background of diabetes because we are apprehended of pelvic inflammatory disease related to IUD. But different investigation has proved beyond doubt that no difference in PID among diabetics and non-diabetics. PID in relation to IUD is practically due to multiple sex partner and other unhygienic behavior. These two are commonly used IUD, we know. Levonorgestrel loaded IUD, it can thicken the mucus, that way it can reduce the sperm motility. The benefit of LNG IUD is that in case of copper T, it can increase the flow during cycle, so we can better avoid copper T in the lady who is suffering from anemia due to some diabetes related comorbidities. The workers have compared the LNG loaded IUD and copper T and they have found no significant difference in terms of fasting sugar, HbA1c and insulin requirement. Coming to combined OCP, initially there was just some barrier to use combined OCP. We know that estrogen, it can suppress FSH and progesterone can suppress LH, that is the way out. But this was a study which was conducted over 1 year and they found minimal side effect on carbohydrate and lipid metabolism following use of combined oral contraceptive pill. And this study has proved beyond doubt that no evidence of progression of retinopathy, nephropathy, hypertension with past or present use of oral contraceptive pill. WHO collaborative study was conducted in the age group in between 20 and 44 and they found OCP was associated with an increased risk of AMI in women with known cardiovascular disease only. So, before we are going to advise for oral contraceptive pill, we should take care in mind that what is the BMI, whether she is smoking, whether she is having migraine. And if the lady is running with all these cofactors, it is better to avoid and not to go beyond 35 years of age. And here is the final verdict possibly regarding OCP. Combined OCP may be used in diabetes without micro or macrovascular disease. But obviously they need more frequent monitoring in terms of to find out the cardiovascular deviation from the normalcy. Regarding postpartum contraception, ACOG has recommended Rather, they have not recommended oral contraceptive pill not before 6 weeks postpartum. It is not going to interfere with lactation only. Rather, there is more chance of thromboembolism as we are using estrogen in the oral contraceptive pill combined. I am not going in details regarding subdermal implant and transdermal patch because there is no strong evidence in favor of diabetes. Emergency contraception, yes, there is no absolute contraindication to emergency contraception in the background of diabetes, but don't forget that you have to advise for a high dose of estrogen and progesterone over a very short period of time. So there are few reports which is indicating that few ladies have developed thromboembolism following emergency contraception. Sterilization can be advised for the couple who has completed their family. Coming to another extreme, hormone replacement therapy in perimenopausal or postmenopausal age group. Earlier it was rather eminence based, it was not evidence based, and possibly the concept of hormone replacement therapy stems from the desire to remain, to stay feminine forever. And if we look back into the history of HRT, we will find that in the 1970 or 80, it was one of the most commonly prescribed drug in the US. Once the lady is developing hot flush, she was advised for the drug, and she started to continue it for years and years. And gradually an assumption was grown that it may be cardioprotective. Based on that idea, ACP in 1992 recommended like this: hormone therapy should probably be recommended for women who have had a hysterectomy and for those, note it, for those with CAD or at high risk for CAD. For other women, the best course of action is unclear. But around 2000, Women Health Initiative and Heart Study report came into light, and we became aware of the high risk of breast cancer, thromboembolism, AMI, stroke, etc. following use of hormone replacement therapy. So there is a drastic change. People started to discontinue hormone replacement therapy, and the prescription fell down like 30 to 40%. FDA came forward with this line of caution: estrogen not to be used to prevent CSD. But what happens post WHI? Gradually the pendulum started moving, and finally it has crossed the fulcrum and entered into the positive territory. Possibly based on this trial and similar trial like this, which concluded critical window of time exists when cardiovascular risk may not be increased and perhaps may actually be decreased by the administration of HRT, particularly estrogen only replacement. So AAC in 2011 started making their guideline, which took the final step in 2017. MST can be advised in case of moderate to severe vasomotor symptom, in case of moderate to severe symptom of vulval and vaginal atrophy. And also certainly there is change in practice. Initiation of HT hormone therapy below 60 years, we should start with minimum dose. It should be advised for minimum duration, and we should prefer some alternative to medroxyprogesterone acetate. There is the contraindication issued by FDA. We should keep it in mind. Regarding protocol, if the lady is having uterus, we should keep it in mind that estrogen should be combined with progesterone. If she is not having uterus, it's only estrogen which is enough. These are the protocol. They are the common type of estrogen nowadays used: CE 0.3 milligram per day, minimum dose, micronized estradiol, estradiol valerate 0.5 milligram, or transdermal estradiol. These are all equivalent doses. One thing I want to mention here: if the lady is not responding to minimum dose of CE, in terms of hot flush, we can increase the dose and we can go up to 1.25 milligram per day. But even if after that she is not responding, we have to think of whether she is having hot flush due to something else, whether she is having pheochromocytoma, hyperthyroidism, tuberculosis or panic attack. So it should be kept in mind. Definitely route of estrogen is very important. We know that if we are using transdermal route, we can avoid a rise in procoagulant, which is associated with oral estrogen therapy. Also, advantage of transdermal route is that we can limit the rise in sex hormone binding globulin, so we can get higher level of free estrogen if we are using transdermal estradiol, that is 17 beta estradiol. There are few studies, I don't say few studies, there are many studies which have shown that HRT can reduce insulin resistance in subject without diabetes, neutral or slightly beneficial effect of estrogen on glucose metabolism. From WHI experience, 21% reduction in diabetes incidence over time in women treated with estrogen progesterone therapy. But this is the final recommendation from ASE. HRT is not recommended for the prevention of diabetes. In women with previously diagnosed diabetes, the use of HRT should be individualized, taking into account age, metabolic milieu, and cardiovascular risk factors. So to conclude, none should be deprived of HRT only because of diabetes if she deserves. But please apply your mind before you are going to advise HRT. Thank you, sir.